All right, let's talk about osteopenia and osteoporosis. So the major topic is osteoporosis, but osteopenia is kind of the precursor. So when you're thinking about diabetes, you also learn about pre-diabetes. So osteopenia is like the pre-diabetes of osteoporosis. So osteoporosis is low bone mineral density. It's also an impaired bone structure, so it's not working like you would like it to. The bones are not as strong as you want them to be, and there's an increased risk of fracture. So the problem with osteoporosis is this issue of fractures. Again, osteopenia is like pre-osteoporosis. And then here's a YouTube video if you want to kind of visualize it. And then I'm going to switch over and I'm going to talk about what's behind me. Let's talk pathophys of osteoporosis. So if you remember back from renal block, we generally store calcium and then we are generally pulling it from the bones to get it into the bloodstream. We have the kidney that can reabsorb calcium, and we have the gut, which is where we absorb calcium that we eat. And so we're getting calcium, but then vitamin D helps us do it better. A couple things we haven't talked about yet are osteoblasts and osteoclasts. So osteoblasts are builders. So I've got a little Bob the Builder right here. Osteoclasts are crashers. So I've got a little wrecking ball. So in osteoporosis, our issue is we have too much crashers. We have more osteoclasts than we have osteoblasts. So when you're thinking through treatment targets, we're going to try to downplay the osteoclasts and increase what the osteoblasts are doing. The couple of hormones that the body uses to regulate this are PTH and calcitonin. So those might also be potential places to provide some pharmacotherapy. So for PTH, if you remember back from renal block, a lot of times people have hyperparathyroidism, and so they might be having too much calcium and phosphate pulled out of the bones and being put into the blood. That activity is associated with osteoclasts. So our crashers are signaled by PTH to crash more. Calcitonin does the opposite. And so calcitonin is in support of osteoblasts. So Bob the Builder likes calcitonin. For everybody with osteoporosis and osteopenia, we want to maximize their absorption of calcium in the gut. So we give generally calcium supplements, and then we also give vitamin D to help the gut absorb calcium better. Can't do anything about the kidney. We hope the kidney works, but we don't have anything to increase calcium absorption in the kidney. If we're treating for osteoporosis or osteopenia, we have a few different medications that we could use. So the most common one, the thing you probably see the most, is bisphosphonates. So bisphosphonates actually go into the bone, and they block the activity of osteoclasts. So what they do is they bind to calcium in the bone, and the osteoclasts aren't able to eat up the calcium in the bone like they normally would. Denosumab is, its place in therapy is basically people who cannot have bisphosphonates because their renal function is too poor. And denosumab is a monoclonal antibody, so it blocks rank L, it's a ligand, and by doing that, that's a precursor, or it's in the precursor cascade to the formation of osteoclasts. So this again is decreasing osteoclast activity. So we have raloxifene. Raloxifene is a selective estrogen receptor modulator. So raloxifene will go in and do things that estrogen normally would. So it's for somebody who doesn't have enough estrogen, like somebody who's been through menopause. And raloxifene will actually decrease some precursors to osteoclasts. They think it's mostly interleukins. So you're kind of blocking the interleukins and decreasing osteoclasts. So all three of those drugs have gone through this mechanism, decreasing the activity of osteoclasts. We have two left. We have PTH analogs, so parathyroid hormone analogs. So they do some of the same things as what your body does with parathyroid hormone. They increase the renal absorption of calcium. They increase the gut uptake of calcium. One thing that they do a little different here. So our PTH analogs, because you're only giving them for a short amount of time, The body's only exposed to them for a short amount of time. And so by giving it for that little amount of time, instead of how it normally signals for osteoclasts to work, it actually ends up signaling for osteoblasts to work. If you think of it, it's done just a tiny bit of crashing, and now the bone is stimulated to start rebuilding. So our parathyroid analogs actually result in building up more bone. And then finally we have calcitonin. So that is this hormone. So we can give this hormone, and that will potentially increase osteoblasts. Risk factors for osteoporosis. So patients are more likely to have osteoporosis if they're female, if they have low body weight, if first degree family had it, if they're older, and if they're Caucasian or Asian Americans. So none of those things can be changed other than maybe low body weight. The things that can be changed are lifestyle factors. So cigarette smoking, drinking more alcohol than is recommended, not eating enough calcium, not eating enough vitamin D, and then physical inactivity are all associated with osteoporosis. We have several secondary causes of osteoporosis, and some of these are going to be things that we're talking about already in the block. So you'll talk about menopause a fair amount in the next block, but that's probably our number one cause of osteoporosis. Similar to that in men, there's testosterone deficiency, anorexia, because if you're low body weight and probably not taking in enough calcium, you can have low bone mineral density. Some other things to call out are diabetes, so type 1 and type 2. Chronic kidney disease, which we've talked about quite a lot. Rheumatoid arthritis, really any autoimmune condition. A lot of times some part of treatment is going to be glucocorticoids or corticosteroids, and so you have an increased risk for osteoporosis if you're on those meds. And then you talked about hypo and hyperthyroidism. So if you are in hyperthyroidism, the osteoclast activity is stimulated, so you can potentially increase osteoclast activity and then decrease bone mineral density. We have lots of medications that can contribute to osteoporosis. So we've learned a lot about anticonvulsants in the neuropsych block. We have aromatase inhibitors, which we really haven't talked about much at all. Thyroid hormones, so that's basically if you're pushing somebody into hyperthyroidism. Gonadotropin-releasing hormones, you'll talk about that in the sexual and reproductive health block. PZDs, those should look familiar. So those are anti-diabetic meds. So somebody who has diabetes has already potentially an increased risk for osteoporosis, and then this medication makes it even worse. Proton pump inhibitors, and then steroids. Corticosteroids, glucocorticoids, these medications are very much so associated with osteoporosis. And in fact, a lot of times you'll have FDA-approved indications for these meds that's just for steroid-induced. There's some others that I included on the bottom. They're maybe not as prevalent as the ones up top. For the clinical presentation, most patients don't know they have osteoporosis until an actual fracture occurs. A lot of times our fractures are in the vertebrae, so in the spine, and a lot of times you don't feel that fracture right away. A lot of people just feel maybe some mild lower back pain, and they usually contribute that to old age. There could potentially be moderate to severe back pain that lasts for a couple weeks, and then a lot of times it'll leave people with chronic residual back pain. If there's a fracture somewhere else, a lot of times you may have more severe pain and swelling and probably reduced mobility. That would be your classic hip fracture. You're definitely going to know that happened. Signs of osteoporosis. You may notice that somebody gets shorter because their spine is no longer as aligned as it should be. And then they may have postural changes. So they may have kind of a hump in the back, and then in the lower back it'll start to kind of lean back in. And people may potentially have fractures that resulted from really a small injury or no injury. So our first learning objective is to determine if a patient is indicated for pharmacological treatment based on their DEXA, T-scores, and FRAX. So a DEXA is the way you say dual energy X-ray absorptiometry. So everybody just says it as DEXA. And you can see this one on the left. This is the diagnostic one. This is a central DEXA, where they're going to actually look at the bones that we were just talking about in the spine and potentially in the hip. The peripheral is a nice, easy thing. You just put your foot in here, and it measures the bones in your heel. You can use this for screening, and some pharmacists will do this as well. We did this at my pharmacy school routinely. We would go out and do screenings for people. So this is enough to say you may have osteoporosis and you should go get a DEXA to confirm. So diagnosis. We diagnose it if they've had a fracture in their hip or vertebrae and there wasn't a traumatic incident, or we can do it by seeing their bone density with that central DEXA that I mentioned. We take that DEXA and it gives us a couple scores, T-scores and Z-scores. So a T-score is what we mostly use for diagnosing osteoporosis. We use it for our standard people, so your older adult. It compares that person's bone mineral density to that of a healthy, young, sex-matched Caucasian reference population. It's expressed as a standard deviation score. So you want to have a score that is within one standard deviation of a healthy person. That means you don't have osteoporosis or osteopenia. We call it osteopenia when you get between 1 and 2.5 standard deviations. And then osteoporosis, we begin to diagnose that once it's at 2.5 and worse. So negative 2.5 or worse. A Z-score is really only useful for your atypical population. So somebody who is younger, who is premenopausal, potentially children, because that's going to compare a bone mineral density at that age to somebody who's of a similar age. In this case, a Z-score of -2 indicates low bone mineral density for that age. So if you do some screenings with that peripheral DEXA, you will get a T-score and a Z-score, and just make sure you know the T-score is the most important thing. Unless you're working with somebody who's younger, then you may look at the Z-score. We also have this assessment of osteopenia called a FRAX, the Fracture Risk Assessment Tool. It's kind of like calculating somebody's ASCVD risk. So you get their lipids, which is like getting a DEXA, and then you assess it by putting it through the ASCVD risk calculator. In this case, we're putting it through the Fracture Risk Assessment Tool. So this was created by the World Health Organization, and it's used clinically in most practice settings. It was intended to be used for people who are postmenopausal and greater than 50 years, and then currently not receiving pharmacotherapy. So it's kind of guiding your decision, should I start it or not? Again, very similar to the ASCVD risk calculator. What it will give you is an estimated 10-year probability of hip fracture and an estimated 10-year probability of a major osteoporotic fracture. So you're going to be more likely overall to have a fracture of anywhere as opposed to just the hip. So if you do this assessment tool, it helps you decide for people who aren't diagnosed with osteoporosis. So if they've had a hip or vertebral fracture, they're going to be diagnosed with osteoporosis, you're going to start them on therapy. If they have a T-score of less than or equal to negative 2.5, you're going to start therapy. The reason the FRAX is helpful is it helps you figure out, what do I do with people that are osteopenic? So it helps you decide if they're osteopenic and they have a high risk of fracture, so greater than or equal to 3% risk of hip fracture, greater than or equal to 20% risk of any osteoporosis-related fracture, then we may want to go ahead and treat them because they have a high risk of fracture. So let's go into the tool. We have a 68-year-old female. She weighs 75 kilos. She's 154 centimeters. Previous history of fracture, yes. No for all of these things. She does not drink alcohol, but she does have secondary osteoporosis. And you have to go down here to see what they consider secondary osteoporosis. I said yes because she has diabetes. Then we put in her T-score, which was negative 1.6. So it tells us her risk of hip fracture is at 1.8, and her risk of major osteoporotic fracture is 14. So she doesn't quite meet threshold to treat. Next, let's talk about the drugs. So we talked about them a little bit already for when you use them. Make sure you know right off the bat, everybody who has osteoporosis and osteopenia, they're going to get calcium and they're going to get vitamin D. The rest of these are extra. So we have this thing we call a bone healthy lifestyle, and this is what's recommended for all postmenopausal women and any men greater than 50 years of age. One is to limit caffeine intake. moderate alcohol intake, encourage smoking cessation, talk about fall prevention, and potentially refer this to PT and OT. Maintain a well-balanced diet, especially with vegetables and dairy, and exercise. We think that weight-bearing exercise might increase bone density, although I've seen some reports that maybe that's not the case. Here we have a list of calcium-containing foods. So it's best if it's digested from the diet, but we a lot of times need to use supplements to get more. You can see a lot of dairy products have quite a lot of it, but a lot of people are lactose intolerant or avoiding dairy because otherwise dairy is not that good for you. But we have a fair amount of calcium in vegetables as well. So calcium and vitamin D. It's recommended that we get 1 gram to 1,200 milligrams of elemental calcium per day. And we can only absorb 500 to 600 at a time. So that means we've got to get it at least two times a day. So that's why when you'll see calcium dosing, it's going to be at least twice a day to get the most bang for your buck anyway. We give our vitamin D to increase calcium absorption from the gut. For most of the US, you'll see recommendations of 800 to 1,000 units daily. That's generally what's recommended. But for us in the Pacific Northwest, we're going to go all the way up to 2,000 because we have such limited sun. Overall clinical trials have demonstrated that supplemental calcium and vitamin D reduces the risk of fractures. Calcium is available in a couple types. So we have carbonate and we have citrate. Carbonate is also the same thing as Tums, also the same thing as our calcium binders, our phosphate binders. So our dosing, again, it's going to be 1 to 3 times a day. You're going to get the most bang for your buck if you separate it as opposed to giving a large dose at once. So if you give calcium carbonate, it actually absorbs better if the environment is acidic. So if you take it while you're eating, you're going to have a more acidic environment and get better absorption. So if you're taking it for calcium supplementation, it's better to take it with meals. Calcium citrate can be taken no matter what. It's not necessarily acid dependent. And so if you do have somebody who has a chronically low stomach acid because they're taking a PPI or an H2RA, the calcium citrate might be better because they potentially might get a little bit more calcium. Adverse effects of calcium, it's pretty well tolerated, but it potentially could cause some constipation. That's probably the biggest thing I hear about. There are lots of drug-drug interactions, so they can decrease the ability of antibiotics like fluoroquinolones and tetracyclines to work. They alter the absorption of them. They could potentially, again, alter the absorption of our thyroid medications, so like levothyroxine. PPIs, H2RAs, they all, again, decrease calcium carbonate absorption. And then a major precaution, if you remember back to renal block, we talked about calcium can potentially cause acute kidney injury from kidney stones. So this is really only an issue if they have renal impairment or if they have a history of calcium-based kidney stones. Overall, for people with renal impairment, we're still going to give them calcium. We just may not be quite as aggressive as we otherwise might be. To remind you about vitamin D, we've got a couple kinds of inactive vitamin D. We've got cholecalciferol and ergocalciferol. We're assuming with osteoporosis that their kidney is working, but if they do have metabolic bone disease, you can still give your activated vitamin D that we talked about in renal block. So normally we get it through the sunlight, which is why in the Pacific Northwest we need to take even more. And cholecalciferol comes from animal sources. So if you have a vegan or a vegetarian person who would like to take if they would like to take vitamin D, make sure they know that they can get ergocalciferol. They both work just as efficacious. So everybody with osteoporosis and osteopenia should get vitamin D. Really, everybody in the Pacific Northwest should probably get vitamin D. You can diagnose a vitamin D deficiency if their level is less than 30. And people who are at risk for deficiency, I'll let you look at that. Overall, if somebody you think is at risk for vitamin D, or if you're diagnosing them with osteoporosis, you should get their vitamin D level to see where they're at. For dosing, we use a little bit different dosing if they are deficient versus if it's maintenance. So you'll see a lot of different regimens for vitamin D deficiency. The big thing to know is that you can give this larger amount, 50,000 units, you can give it once or twice weekly. And then that will hopefully boost you up. And then that's going to be prescription strength only. And then you can switch to OTC. And then if you're giving OTC Vitamin D3, you want to give much larger doses than you usually would. So 4,000 to 7,000 units daily. Once the levels are restored, you go back to maintenance therapy. And you don't want to overdo it because vitamin D is fat soluble. So if you get too much vitamin D, it's going to be there for quite a while. Again, in the Pacific Northwest, I'd say about 2,000 units is going to be best for maintenance therapy. So the adverse effects of vitamin D, pretty well tolerated. The biggest issue is going to be hypercalcemia and then potentially hyperphosphatemia. Those are going to occur in vitamin D toxicity. So you're going to have too much calcium and phosphate absorption from the gut. If somebody has hepatic or renal impairment, they might be at a slightly higher risk for vitamin D toxicity. And then, if somebody's just taking tons and tons of vitamin D, they potentially have a risk. Really, the only contraindication to vitamin D therapy is if they already have hypercalcemia. So that should sound familiar from renal block. We didn't want to use vitamin D or active vitamin D when somebody's calcium is already high. So it's just going to make it worse. Treatment for osteoporosis. So we talked about these meds already a little bit. Our bisphosphonates are all first line except for, unfortunately, ibandronate. But we have multiple oral options in the bisphosphonates. We also have an IV option in zoledronic acid. The denosumab is only an injection. And teriparatide and abaloparatide, those are your PTH analogs. Those are only available in injection as well. And calcitonin is last line, mostly because it doesn't work that well, but it is available as a nasal spray. It also can be IM or other sub-Q injections, but most commonly you see the nasal spray. So I'm sure all of you have counseled on bisphosphonates at this point. Again, they bind to the calcium in the bone. And by binding to that calcium, they inhibit osteoclast activity, which is going to reduce bone resorption. So their first line, except for ibandronate, it doesn't have the same evidence as our other ones. So the nice thing about most of our bisphosphonates is they reduce both vertebral and hip fractures. The reason why ibandronate is second line is because it only has been shown to reduce vertebral fractures. We look at the monitoring parameters and things like that for bisphosphonates. Luckily, these are pretty rare side effects, but these are all going to be kind of your big black box warnings and things you should warn people about. So atypical femur fractures, normally people don't fracture their femur, but if they take bisphosphonates, they're a little bit more likely to. Esophagitis, inflammation in the jaw, and then osteonecrosis of the jaw. Luckily, osteonecrosis of the jaw is much more associated with people who are getting cancer treatment doses because it can be used to treat bone cancer. And they're also going to be a lot more likely in people who already have pre-existing injury and infection in their jaw. It makes sense that getting lower calcium and lower phosphate could happen. And I would say the dyspepsia is fairly common as well as dysphagia. All of them, unfortunately, are renally eliminated, so we can't use any of them if somebody is CKD stage 4 or below. This should say hypocalcemia, so if they are hypocalcemic, we can't start it yet. We got to get their calcium up first. And then if they have history of osteonecrosis of the jaw, we're going to get rid of it. And then finally, if they're not able to stand or sit upright with any of our oral bisphosphonates, we can't use them. We do luckily have a non-oral option, so we could use our zoledronic acid in those patients. Counseling points. So when people are taking an oral bisphosphonate, they need to drink 6 to 8 ounces of plain water to make sure that med gets down there and isn't causing that esophageal irritation. They need to take it before they eat, because again, that's going to get out of the GI tract faster, and then they want to separate it from any other meds. After they take an oral bisphosphonate, they need to remain sitting up or standing for at least 30 minutes. Ibandronate actually increases up to 60. We also have risedronate delayed release. So this one's got a kind of different release mechanism, so it shouldn't hopefully cause that esophagitis. So that one should be taken immediately after breakfast with 4 ounces of plain water. So this one potentially could be better if somebody maybe can't sit and stand, but it's not going to be as safe as your IV option. They need to get dental work before starting their meds because of the osteonecrosis of the jaw. And then the PPI, H2RA, and antacids, those can decrease absorption. So the H2RA and antacids are only if it's taken right prior. The PPI is probably not going to make a big difference because it's more of a long-term drug. All right, so let's talk dosing. So you do need to know dosing for bisphosphonates because it's really important to recognize if you're giving treatment, dosing, or prevention. So for alendronate, that's probably our most commonly prescribed med because it is available as generic. I'm mostly seeing weekly dosing because it's probably more convenient for most people. So it's 70 if it's for treatment and only 35 if it's for prevention. So somebody with osteopenia. For zoledronic acid, it's the same dosage, but it's less frequently if it's for osteopenia. So it's once a year for osteoporosis or every 2 years for osteopenia. Boniva and risedronate are both a little bit easier to remember because they're both 150 milligrams monthly, and they're going to be the same dose if it's treatment or prevention. And abandronate is available IV, but I only see zoledronic acid. For risedronate, there is only an FDA-approved dosing of 35 milligrams per week for males. I don't know if people use the other approved dosings for males, but I suspect they probably do. So a little bit more about zoledronic acid. So you might think to yourself, why would anybody want an infusion? Well, zoledronic acid, because it's only once a year, it really can be a lot better for people who have dementia or cognitive disabilities, so they're not able to follow all the instructions with the oral meds, or if they have physical disabilities, like they can't remain upright, or maybe their GI tract doesn't work properly. So since this is only once a year or every 2 years for prevention, it's really pretty similar cost as well because you're not paying for all these copays chronically. You're just paying for this one-time infusion. And the nice thing is the infusion is quick. It only takes about 15 minutes. When we're talking about duration of therapy, we actually don't have to treat for as long as we used to think we did. Bisphosphonates luckily stay in the bone because they've bound to the calcium and kind of become part of the bone. And so they have an extremely long half-life. The only reason they get broken down is because of normal osteoclast activity. So we have new guidelines that say that you can consider discontinuing your therapy after 3 to 5 years of treatment. The only type of patient that we might continue it even longer than that is somebody really at a high risk of fracture. So I'll let you test your understanding. Go ahead and pause this video and try it out for yourself. If you haven't paused it yet, now is the time because I'm about to tell you the answer. Your best option here is going to be risedronate because zoledronic acid and alendronate are at your osteopenia dosing, and abandronate isn't first line. So denosumab. This one is an injectable, so that's not quite so ideal, but the nice thing is it's not very frequent. So again, only every 6 months. So this also might be a good option for somebody who is similar to the patients we discussed already for zoledronic acid. So it is a monoclonal antibody, and as I mentioned, it binds to wrinkle and then blocks rank, which is involved in forming osteoclasts. It is considered a first-line therapy because of its high efficacy, and its other place in therapy is even zoledronic acid. It can't be given to people whose creatinine clearance is less than 30. So that's really where we use it the most. It is going to be your most expensive option of your first-line therapies. It does have great efficacy, so it reduces vertebral fractures and hip fractures, and then overall fractures. Your adverse effects, so again, it's only every 6 months, so luckily it's not going to be as frequent as it would be with a bisphosphonate, with an oral bisphosphonate anyway, but potentially you have some kind of normal ones. You would expect hypophosphatemia makes sense. Dyspnea might maybe be a little bit more surprising. Osteonecrosis of the jaw is still possible. So is atypical femur fractures. It cannot be used in pregnancy or lactation. And similar to bisphosphonates, if somebody has low calcium, it has to be corrected first. It does have a precaution in creatinine clearance of less than 30. So it's not contraindicated. We just have some extra monitoring. And the biggest thing there is just making sure their calcium and phosphate is taken care of as good as possible. Can't be used in hypoparathyroidism, which makes sense because that's going to mess with your calcium and phosphate. Shouldn't be used in patients who are having thyroid surgery or malabsorption syndromes. So again, these are all things that increase the risk of hypocalcemia, so not absolute contraindications, just extra precautions. So denosumab, as I mentioned, is subcutaneous, and this one actually has to be given by a healthcare provider. It can't be given by a patient, and it actually has a REMS for it. One unfortunate thing about it, which bisphosphonates have the property that they continue to work for a long time. For denosumab, once you stop it, it will stop working. And you could potentially have rapid bone loss after that. Okay, so here's our estrogen medication, raloxifene. So this one we're only going to use for people who have postmenopausal osteoporosis. Not going to use it in men. The nice thing is, because it's selective for the estrogen that affects bones, we're not going to have the increased risk of breast and uterine cancer, but we still do have some other side effects that are due to estrogen. It can be used for treatment or prevention, same dosing either way. And it does work by decreasing vertebral fractures, but doesn't decrease non-vertebral or hip fractures. So another reason why it's maybe a second-line therapy. The adverse effects are based on its estrogen-like properties, so it makes sense there might be some more hot flashes and some weight gain. The black box warnings are both about clotting issues, so increased risk of venous thromboembolism, increased risk of death due to stroke, especially if a patient has coronary artery disease or is otherwise at risk for coronary events. It's contraindicated if they have an active VTE, contraindicated if they're pregnant, because it's a hormone, so it's going to change that, and then contraindicated in breastfeeding as well. You don't want to mess with your pregnancy hormones. Counseling points. So this one is also not efficacious after it's discontinued. It does need to be discontinued prior to surgery or prolonged immobilization because of that risk of VTE. There are several drug-drug interactions because it's highly protein-bound. And so if you have another drug that's highly protein-bound, you can alter the pharmacokinetics. We have parathyroid analogs. These are pretty new on the market. Teriparatide's been around for a little bit longer, and abaloparatide is brand new. So I have no experience with either, honestly. I've at least heard of teriparatide, and I hadn't really heard of abaloparatide before. I mentioned that the mechanism, it acts kind of like PTH, except that since it's only there for a short amount of time, it's going to favor the actions of osteoblasts instead of osteoclasts. And the black box warning with these, it makes sense because these guys are there to stimulate bone growth. And if you're stimulating growth, that sounds an awful lot like cancer. So bone cancer is potentially possible after starting these agents. So these are really reserved for people who have really severe osteoporosis and really need treatment. So teriparatide, brand name is Forteo. It's given once daily, so once daily injection. If somebody has a really high risk of fracture, you can potentially even bump this up to first line. Just think of it in general as a second line agent. The nice thing is it does reduce both vertebral and non-vertebral fractures. We haven't seen evidence for a reduction in hip fracture. It does potentially cause orthostasis and dizziness. It can potentially cause arthralgia, so pain in your joints, hypercalcemia, nausea, and leg cramps. This is our other one, abaloparatide. It's also given once daily subcutaneous injection. I don't necessarily care that you know the milligrams for these, as long as you know that they're once daily subcutaneous injections. This one causes a little bit less hypercalcemia than our other one, but we still have the same risks of orthostasis and dizziness. This one can increase uric acid and potentially cause swelling at the site of injection. You need to store, for sure, the teriparatide. I'm not sure actually about the balance. Let me get my note. So both of these need to be stored in the refrigerator. They're both good for about a month after they're opened. And for administration, they want to administer in a fatty tissue, again, subcutaneous, once daily. It's best to try to pick the same time each day to inject, and the duration of therapy for both of these agents is only 2 years. At that point, the risks of things like bone cancer outweigh the benefits. So after they've used these, they can switch to bisphosphonates or denosumab. We've got one drug left. We've got calcitonin. So remember that calcitonin is a hormone that's naturally found in the body. So basically, we're just giving hormone that we found from somebody else. In this case, we take it from salmon. So it directly inhibits osteoclast bone resorption. Most of the time I see it in the nasal spray. It does exist as subcutaneous or intramuscular injection, but I usually see the nasal spray. And if you do the nasal spray, you do in one nostril one day and then switch off to the other one the next day. It's last line. It's really only FDA approved for treatment in women with at least 5 years past post-menopause, so not really technically FDA approved for men. The efficacy isn't as great. So we do have decreased vertebral fractures, but we don't have any evidence from our injectable formulations. So for your intranasal, we can potentially have some nasal symptoms, no surprise there. The biggest thing that can happen is if somebody is allergic to salmon, they should avoid this product because it's all coming from salmon-derived products. If they have an unused bottle, they should store it in the fridge and then allow it to reach room temperature to make it more comfortable. And then again, alternate nostrils daily. Last line, so I don't see it very often for osteoporosis. So here's a look at the monitoring. So we've talked about if somebody has a normal bone density, how often do we monitor it? We just kind of follow up again every 5 years or so, and then maintain our bone healthy lifestyle and get good calcium and vitamin D. If somebody is determined to have a low bone density, so osteopenia, but their frax is relatively low, we potentially could start a medication if there's some other reason why they might need one. But for somebody like this, we're going to follow up a little bit more frequently, and we'll get their DEXA in around 2 years as opposed to waiting to 5. And then if somebody is actually being treated, we should reevaluate their bone mineral density in about 1 or 2 years after we've started something. And that is basically summarizing up the same stuff. For osteopenia, I think one more point in here that wasn't in the last one is that we should go ahead and do another frax for somebody if they have a new fracture or some other factor that's changed their frax. So you'd potentially still be using their same DEXA from before, but because their patient risk factors have changed, then you're going to calculate a new frax. So it would be like if they started smoking or if they had a new fracture. All right. So when we're looking at efficacy, the National Osteoporosis Foundation recommends getting a repeat DEXA again within about 2 years of starting treatment, and then you compare your new result to your old one. If a T-score continues to worsen, so say before it was 2.7 and now it's 3, maybe we need to switch medications, probably to one of those more potent ones like teriparatide. If it improves or remains the same, then we're going to consider continuing the same therapy for 3 to 5 years, or we could potentially give a drug holiday. Additional monitoring, we want to keep track of their height. If we see decreases in height, again, that's a sign of vertebral fractures. We want to keep track of their vitamin D levels, and then we want to make sure if they're on a bisphosphonate, we are following the renal function, at least annually. And then I have posted a little review activity for you guys. I do have a review activity for you guys. I think it was originally created by Danielle Small, who was actually a graduate of Pacific University, and she taught this last year. So this is a nice little Jeopardy game that you can come in and you can either play it by yourself or you can play it with friends to have a little bit more fun. It should be a nice review of the material and make you go back to the slides if there's things that you forget. For exam, I'm just going to ask multiple choice questions with one right answer. So you'll have a patient case or a quick question and have one right answer. The material to go back and study is the learning objectives. So they're related to assessment and diagnosis of osteoporosis and osteopenia. So what do the T-scores mean? How do we use a frax? What's it for? And then for the pharmacotherapy, it's going to be your standard stuff about given a patient scenario, which pharmacotherapy would be best, which monitoring parameters should be done while they're on it, how is it available, that kind of stuff. In order to reach me, go ahead and use the discussion board on the on Moodle. Sorry, I'm going to be traveling to American Society of Consultant Pharmacists on Halloween, so on the day that you're watching this, and then I will be there by the evening on Wednesday. So I should have access to email and everything like that, just maybe a little bit slower to respond. So if you use the discussion board, then maybe somebody else can respond even before me. I would also say that you can use Dr. Begert as a really good resource as well, because not much has changed in osteoporosis. So he can likely answer any question as well. But again, go ahead and use the discussion board. I'll check it and see if there are questions that I can answer. If you send me an email, I'll just post that on the discussion board as well. Trying to think if there's anything else to let you guys know. I think that's it. I hope you guys are doing well. Hope you have a happy Halloween, and I will see you when I get back.